Good afternoon.
Good afternoon.
We're just doing a double check on the IT, but now we are good to start. Welcome to session 6, Gendered Impacts of the Covid-19 Crisis, which is actually my favorite session, not just because I'm helping Professor Nitya Rao coordinate, but also because it's a completely women panel. And we'll be discussing with the panel chair, Dr.SoumyaSwaminathan, who right now needs no introduction from any part of the world because of so much of information that is being given from WHO on the COVID pandemic. Professor Nitya Rao from the University of East Anglia, Ms. Poonam Muttreja from the Population Foundation of India, Dr. Avni Amin from the WHO gender team, Dr. Kezevino Aram, who is also our trustee, but more than that, she's been doing a lot of community work at the Shanti Ashram, Dr. Anjana Mangalagiri from the Institute of Social Sciences, who has rich experience and background in education. So I'd like to first just give a very brief overview about the session as such. Why this session? The session was actually thought of because there was a sense that there's so much being spoken about around the COVID pandemic, but are we really looking at how the impacts, the gendered impacts of the pandemic is influencing various aspects? This ranges from the care burden of women, the additional care burden of women, to the decreasing nutritional intake, and it also looks at sexual and reproductive health, education of children, especially the girl children, and lots of other underlying factors. So the panel was actually thought through very carefully to bring together all of these views in a way that we will get a cohesive and a more comprehensive look at what is happening from the gender lens on COVID, something that we should really be talking about. Also to mention here that the foundation has this year instituted a Meena Swaminathan Fellowship for Gender and Development for journalists. And when we were looking through a number of articles to actually see the writing that has been happening from the point of view of women or from the point of view of gender, it was really quite limited. So this is also given rise to the fact that we need to definitely focus much more on that. To introduce our panel chair formally, so Dr. Soumya is a very, I must say, very inspiring person, extremely, quietly stated, but very impressively has worked in health, TB, HIV for several years, was heading ICMR before she moved to the WHO, was Deputy Director General Programs, and is now Chief Scientist. And what has been very remarkable about her stint at WHO, at least for me, is the fact that she has been putting out information and accurate information from a scientific perspective comprehensively and very consistently. And this is something that's really needed. So that's my little bit of introduction for now. And with this, I would like to hand over to Dr. Soumya.
Thank you, Jayashree, and good afternoon, also good morning and good evening to colleagues from all over the world who are watching this program. I think this session today is addressing a very important and perhaps neglected topic of the impact of COVID-19 looked at from a gender perspective. And I think we have a very eminent group of panelists today who will be discussing various aspects of COVID-19 and its impact on women and children and both the work and the home environment. So very briefly, I'd like to give a few opening remarks before we go into the panel discussion, which promises to be very lively and interesting. The first thing I think is to note that pandemics and outbreaks, emergencies in general, have differential impacts on women and men. Right from the risk of exposure to biological susceptibility, a lot of it we still don't really understand, not just for this disease, but for many other diseases. Why men and women, and a disease that I've worked on myself for many years, tuberculosis, has 3 times a higher incidence in men than in women. And we don't know exactly what are the biological and environmental factors, but the fact is there is a difference. Also, the experiences of men and women are likely to depend on biological and gender characteristics and their interaction with other social determinants. Therefore, both global and national strategic plans for COVID preparedness and response, they need to be grounded in a strong gender analysis and ensure meaningful participation of affected groups, including women and girls, in decision making and implementation. Now, I'd like to make 5 or 6 points, and which are related to the actions that countries or member states governments need to take. The first is the limited availability of sex and age disaggregated data. This hampers the analysis of the gendered implications of COVID-19 and the development of appropriate responses. So the WHO, of course, receives health data from all our member states. We have 194 member states. But based on the data that's reported to us through the international health regulations, up to April, only 38% of countries were actually reporting the age and sex disaggregated data. And therefore, it's very difficult to really tell how the disease is affecting men and women. And it's difficult to interpret gender differences and also across age groups. There may be geographical variations in infection rates and death between men and women in different parts of the world. And that's very important to understand the factors behind that. So data on tested individuals, their severity of the disease, the hospitalization rates, the discharge rates, and the health worker status disaggregated by sex and age at a minimum, as well as other stratifiers wherever possible, like socioeconomic status, ethnicity, gender identity, refugee status, and others where feasible, could help both identify and address the COVID-19 related health inequalities. So the first request really to member states and partners are to collect and report and analyze data on COVID-19 cases disaggregated by sex and age, plus all the other factors that I mentioned, and also to undertake a gender analysis of data and invest in quality gender responsive research on the differential impacts of COVID-19 on men and women. So this is the first point. The second is that as countries put in place these very stringent lockdown measures, a large number of reports coming in from different countries about increased incidence of intimate partner violence or domestic violence, both against women and children. Also, women's care burden increased, livelihoods were affected, access to basic necessities were reduced, social and protective networks were disrupted, and services for survivors also diminished. So increased stress in the household. So health sector actually has a critical role in mitigating the impact of violence on women and children as part of the COVID-19 response and ensuring access to services for survivors of violence. So again, the second request really to member states is to include responses to violence against women, particularly intimate partner violence, as an essential service. We have a list, all governments have a list of essential services, and it's important that sexual and reproductive health services, as well as services on for survivors of violence, be included in those. Because governments are making choices between which essential services to continue in the face of the lockdown and the other constraints. And we know also that abortion services and contraceptive services have been interrupted in many countries, and it is expected that there will be a large increase in the number of children being born as a result of the interruption of these services. We also know that nutrition services, immunization services are interrupted, leading to increase in childhood morbidity and mortality, as well as outbreaks of vaccine-preventable diseases. So the third point is to ensure that these essential health services that are being provided include access to sexual and reproductive health services. Then coming to the healthcare workers themselves. We know that women constitute 70% of the global health workforce, and they are highly represented at the front lines. And therefore, they are at high risk of frequent exposure to COVID-19. And there is data from some countries like Spain and Italy showing that of all the healthcare workers that were infected, over 70% in the case of Spain and 66% in the case of Italy were women. So we need to collect data on COVID infections among healthcare workers and other social care providers and put in adequate safeguards for the health of these people who perform essential duties, both men and women, of course. And training is very important. Training in the infection prevention and control practices, training in how to use personal protective equipment, providing essential products, both PPEs as well as products for hygiene and sanitation, as well as psychosocial support. We've seen also in many countries a burnout happening among these frontline workers. Working hours and shift assignments should be adjusted to prevent burnout, and resources made available for mental health and psychosocial support, as well as sick leave, insurance, and prompt payment of salaries. And women health workers, including women nurses, must be meaningfully involved in national, subnational, or organizational level decision making about the distribution of resources, equipment, policies, and practices that impact their health and well-being. In fact, there was the nurses in the UK actually had made a request to the government saying that the personal protective equipment that was being supplied to the hospitals was not designed for women's bodies, and therefore it was ill-fitting and probably less effective. And normally when these things are designed, generally it is designed for a standard man. And so it's very important that their inputs and their voices and their feedback be collected and listened to. So again, another action for governments is to ensure that all frontline health and social care givers and caregivers, in our case the Anganwadi workers, the ANMs, the ASHAs, the village health nurses, the sanitary inspectors, nurses and doctors in hospitals, all of them need to be given training as well as provision of personal protective equipment as well as other essential products. And it's very important that psychosocial support be also provided, taking into account the specific needs of women, who, as I said, constitute the majority of frontline workers. Another challenge facing us is inequities in access to information, prevention, care, and financial and social protection. This is likely to disproportionately affect the poor and other populations that are facing social exclusion, and this can potentially exacerbate these inequities. We know that disease and deaths disproportionately affect some groups due to a range of factors. For example, people who are living in overcrowded conditions and those who are lacking basic water, sanitation services, etc., they do face increased infection risk. They can also have less ability to comply with physical distancing. It's just not possible. They may not have clean hand washing facilities, because we know globally 4 in 10 households lack soap and water on the premises. In urban slums, people have to share bathrooms and share water facilities. So all of this actually leads to a higher risk. And therefore, we need to really look at these factors and remove financial barriers or other barriers to access to COVID testing and treatment services, making them free at the point of use, and making sure there's equitable access not only to healthcare services, but also to water and sanitation facilities, especially in our underprivileged communities. And then, of course, safety nets are very important. Various kind of social security measures and safety nets, including unemployment benefits and other kind of benefits wherever it is possible, should be implemented. And then finally, there's fear and stigma about COVID-19. This can lead to social stigma and discrimination. And we have seen many, many instances being reported in the media where a person who's infected or even suspected of having COVID-19 infection is prevented from entering their own houses, is prevented from entering villages, is prevented from entering a workplace. And that kind of stigma and discrimination against infected people is very, very, is a terrible addition to the problems which already they may be undergoing. And we've also seen that there have been certain ethnic groups that have been targeted due to false information or rumors and misinformation circulating about certain ethnic groups being the source of infection in some countries. Now, stigma and discrimination obviously has a huge negative effect on the physical, mental, and social health of people. We've seen this before in diseases like HIV, and it's only because of a huge global community of HIV advocates and activists that stigma and discrimination have been reduced to a large extent. And it also then results, it could result in physical violence, it results in social rejection, limiting or denying access to healthcare services, education, housing, or employment. And therefore, we need to ensure that we keep on underscoring the fact that health is a human right and that emergency responses to COVID-19 should be inclusive and non-discriminatory and avoid the use of excessive emergency powers to regulate day-to-day life indefinitely. And again, governments as well as communities need to take measures to identify and counter stigmatizing and discriminatory processes. And here I think the media can play a very important role in pointing out, just like we have a big campaign on how to report on suicides. And there is a norm on how one reports on suicides and HIV and so on. So there needs to be some norms on reporting on COVID-19, including the maintaining the privacy and confidentiality, but also providing correct information to people so that unnecessary stigma and discrimination can be avoided. So these are some of the implications that the WHO actually had identified fairly early on in this pandemic with a view to encouraging both governments and civil society to think about this and take action as appropriate. Now, today we're going to look at different aspects of the impact of COVID-19, and I'm going to now turn to our panelists. And our first speaker is Professor Nitya Rao, who's a professor of gender and development in the School of International Development, University of East Anglia in Norwich in the UK. And Professor Rao has done extensive work in India as well as many countries in Africa, particularly focusing on the impact of land ownership laws on rural and tribal families and how gender can really impact the role that women have in those societies and how it also impacts not only on their own lives but also on the families and particularly the children. So she's going to speak to us on the gendered impacts of COVID-19 on women's work, food, and nutrition security. And I had a couple of questions for each of the panelists, which I hope they will answer through their presentation. And the first one is really to tell us what's been the effect on women's work, both productive and domestic, which is often neglected during this COVID-19 induced lockdown. And also, what could you see as short-term and long-term impacts on both family and women's nutrition, and what are the strategies to address them? Nitya.
Thank you very much, Soumya, and good afternoon to everybody. And it's really an honor and a pleasure to be here and to make some comments on the gendered impacts of COVID that we are seeing in the last couple of months. And I'll focus now mainly on India because I have been here actually during the lockdown, right through the lockdown, and I would like to present some of my insights. But I want to start with two small stories or vignettes on women's work. The first one is from long-term work that I have been doing in Jharkhand in the Santhal Parganas with Santhal women who have been migrant workers, agricultural migrant workers historically, and at least from the 70s or the 80s to West Bengal several times a year for a couple of weeks each time for planting paddy, harvesting, and also for potato. And most recently in March, they had migrated to West Bengal to Bardhaman for the potato harvest, which is very interestingly called Alu Jom. So the importance of agricultural work with food, I think, is very significant, that potato as food, and they also get paid in both cash and kind, a sack of potato along with some cash wages. Now what happened, by the time they finished harvesting, the lockdown had been announced at the end of March, and they did not have any transport to travel back home. So these women walked back something like 150 to 200 kilometers, but of course they couldn't carry their sacks of potato. So they had to leave that behind or distress sell it cheaply in Bengal and just come back with whatever cash they had. So they lost a source of food, and of course they lost income which could have been used for other purposes. My second story is from Western India, from Udaipur district, which is also a tribal population, Bhils. And the men from here, they migrate to Gujarat, to several cities in Gujarat, to Udaipur, Surat, Rajkot, Ahmedabad, and so on. And I think, as we've been hearing in the news and through media reports again, that first of all, most of these are informal sector workers working in hotels, working in factories. They don't have any guaranteed legal status as workers, therefore no benefits or secure working hours and so on. Now what happened during the lockdown is, thanks to an NGO working in this region, Ajivika Bureau, they were able to get home. But they had a lot of difficulty prior to that in the 1 month that they took to get home, because they had no money, they had no food, the employers were threatening to beat them, the landlords evicted them because migrant workers again were stigmatized, and local government was preventing them from coming out of the houses because they said of the threat of COVID. Now they returned home very tired, very exhausted, anxious mentally. But it's very interesting that the government then set up Narega, or the Mahatma Gandhi Narega employment guarantee in these villages. But 95% of the workers on Narega sites were women, even though the men had returned home. And this is very interesting that the women themselves noted there that, men have come back very tired and so on, they have to rest, but also it is our responsibility. When men go away, they work, they earn, they provide, but in the village, at home, it is our responsibility to provide food for the home. And this time the men came back without anything, so we have to work double hard in order to provide for that. So I think there's also this whole responsibility in terms of gender roles and relations of women feeling responsible for household food provisioning. So what has happened really in terms of the impacts of the lockdown, the loss of employment, and so on women's work burdens? As I already said, a majority of women, and in fact men, are in informal employment. Women particularly in domestic work, services, petty manufacturing, and so on. And these were the first to be affected. They were the first to be closed down. Live-in maids, we know in most cities, were prevented from coming to work in middle-class homes. They got no income. And at the same time, if they were living in rental accommodation, they had to pay the rents, they had to look after their family, they had to cook food for their families, and so on. So this was a negative impact. They lost jobs, they lost incomes. The ILO has also reported that 400 million jobs have been lost globally, but women were the first to be laid off and suffered the worst income losses. The second aspect, I think, again, from a gender perspective, linked to stigma and so on, is the whole issue of dignity, which is very important. These people who lost their jobs were virtually converted to beggars, even in their own home places. They were dependent on charities, on NGOs for daily food packets. This was not often according to their taste. They had no access, especially in urban areas. I think Dr. Soumya just pointed out in terms of clean drinking water, let alone for washing hands frequently with soap, and so on, living in slums. Many of these slums became containment zones, and these people were not even allowed to come to the common tap to collect water. So real loss of dignity, treated almost like prisoners or jailed inside their homes. We saw these early pictures from Dharavi in Mumbai as well. There were two other very important things. One is that where the women didn't move, but they stayed in the rural areas, the men were desperate to come back home. They had no income, as I already said, and therefore they were charged very heavily till such time as the trains were set up, and there was a lot of controversy about who will pay for the train fares, that large amounts, trucks, private tempos, vans were charging from these migrant workers, and the women were actually selling off their assets, mortgaging their jewelry in their rural homes in order both to pay for their men to come back, but also to maintain households, because the men were coming back with no incomes. And finally, increased care burdens. For children were not in school, they were at home, the mothers had to look after their home along with managing Nariga or other kinds of work. The elderly, the sick, the men were coming back into quarantine centers. They were not getting food, not getting adequate care in the quarantine centers. So additionally, the women were having to cook food, take it to these quarantine centers and so on. This has led to a huge increase in the length of the working day. So I think that has been the impact in terms of women's work. Huge increase and intensification of women's work. Very quickly, I want to turn to what has been the impact on food and nutrition security and link it a little bit to the Sustainable Development Goals. So SDG 2, of course, is on food and nutrition security, on the removal of hunger and food security. And this really has been recognized as a kind of human right to food. And as per the FAO definition, well-accepted definition of the right to food and food security, there are sort of 6 dimensions. The 4 much more accepted in terms of availability, access, utilization, and stability, but 2 others which are very important from a gender equality lens. The agency of women, their ability to choose, their ability to have food according to their preferences, and also sustainability for the long term. Now, all of this has been very badly impacted by the COVID pandemic. And I just will highlight a few points that in India, thanks to good harvests and also sufficient food stocks, the public distribution system in India has distributed more than 27 metric ton of basic cereals as of July, some pulses and oil, which was free or at subsidized rates over the last 3 to 4 months. But of course, in the newspapers yesterday, we read that this additional pulses and oil is to be discontinued from the month of August because the state governments don't have money, the finances, in order to distribute these. So people will be left with basic cereals, which is great as far as calories are concerned. But of course, food and nutrition security has to be much more than calories. Nutrition, of course, requires proteins, micronutrients, various other kinds of things, and market disruptions, supply chain disruptions have really meant, and also the loss of jobs has meant that people don't have the purchasing power. They have reduced income, and this has adversely affected not just availability because of the disruption in transport and so on, but also affordability in terms of, and choice, in terms of fruits, vegetables, eggs, meat, milk, pulses, what we would call as a healthy, nutritious diet. Majority of people are getting cereals from the public distribution system, but nothing else is really affordable. And of course, the third element, which is very important for nutrition security, is clean drinking water, sanitation, and public health services. And all these have been disrupted. Public health is there, but is completely focused on COVID-19 awareness and response. So in the Santhal Parganas where I work, where I had visited, things like spraying for malaria control, which usually takes place in the months of April, May, because it's endemic to malaria, has not happened this year. Similarly, immunization has not taken place. Nutritional inputs through Anganwadi centers have not been given. So we don't know what is going to be the longer term impacts on health. So my final concluding point, in just a minute, is what might be the strategies to address this in terms of a longer term. And I think one very important thing is that addressing the devaluation of women's work, really recognizing women's work. It is so invisible, whether it is migrant work, whether it is unpaid work at home, domestic work, it needs to be recognized, it needs to be valued, number one. And number two, that all forms of violence, I think Dr. Soumya also mentioned this, and one very critical reason for violence is what we call as food-related violence, because woman is responsible for cooking and producing the food. If she doesn't cook properly, or if she doesn't have food on the table, she's also, it's seen as a justifiable reason for intimate partner violence. So I think the two are really interconnected. So I think a few points linked very much to the SDG 5, if we want to achieve SDG 5, especially 5.4, which talks about the recognition of women's work, the redistribution of women's work, and the reduction in women's work. I think these need to be taken seriously. And it is not only with unpaid care, which is what 5.4 is about, but it's also about recognizing women as workers with equal access to resources, with financial resources, entitlements, public resources like social protection measures. We need to urgently ensure that food, which was to be given through Anganwadi centers, school midday meal programs and so on, has to be reinstated, whether or not schools and Anganwadi centers are operational. And finally, we need to, I think, the point again about voice and leadership in terms of decision making around their lives. The unequal institutional norms which absolutely hides and invisibilizes whatever women do needs to be reversed. Thank you very much.
Thank you very much, Nitya. I think we'll go on to the next panelist, and I encourage all our viewers to type in your questions into the chat box, and we will try to have address some of those questions at the end. So I'm going to now invite Ms. Poonam Muttreja, who is the Executive Director of the Population Foundation of India, has over 40 years of experience in development, both setting up and heading NGOs and contributing to policy and advocacy, and creatively building the field of reproductive health, strengthening communications for social good, promoting innovations, and scaling up pilots, besides, of course, advising and mentoring a number of people. She's a very strong advocate for women's health, reproductive and sexual rights, family planning, public health, and rural livelihoods. So, Poonam, I'd like you to address the following questions. What are some of the major impacts that we're seeing in your experience of the impact of COVID on sexual and reproductive health services and violence against women? And of course, where do you see the solutions? How can these be addressed?
Thank you, Soumya. It's an absolute honor to be with you, Nitya, and the other panelists, and talking about an issue which is an unfinished agenda, even from before the pandemic. Can I have my slides, please? Slide 1. You know, gender-based violence and many other issues around which women experience, challenges along several dimensions, are likely to get exacerbated as the pandemic and its impact unfolds. So these are, on the left, you'll see some of the key concerns which are not comprehensive, but some of the concerns I have put down that were already there before the pandemic. And they're going to get, as I said, highlighted and exacerbated more, especially if we talk about girls. Apart from nutrition, education, many of them will drop out of school, early marriage, and so on. But given the pandemic, we are seeing disruption of essential health services, which Nitya also referred to in our observations in the field during the nationwide lockdown, and constrained already the already limited access that women had to reproductive health services, safe deliveries, contraceptives, and pre- and postnatal care. Several media reports have stated that there has been 40% decline in institutional deliveries. And this was also there when we had the data online, which has been taken off. There is no more data in the HMIS on the number of institutional deliveries, which we used to get every month earlier. But even if 40% is an underestimation, it's going to impact women's maternal health and child health and mortality for both. A recent study estimated that 26 million couples in India will have no access to contraceptive during the disruption of the family planning services due to lockdown. As you all know, sterilization is the mainstay of India's family planning program, and there are no sterilizations happening. Results from 2 studies that the Population Foundation of India did to assess the impact of COVID have yielded results which set alarm bells ringing. Nearly half of frontline health workers have reported, which is ASHAs and ANMs, that women are not accessing antenatal care. Even if the services are available, women are not accessing services. Communities are scared. The fear factor that Soumya referred to in her opening comments is very much there, and therefore young people, we also found that young people in 4 states, 3 of the 4 states that we looked at, which is UP, Bihar and Rajasthan, reported an unmet need for reproductive health services, sanitary pads. There's been complete breakdown in access to sanitary pads during the lockdown. And the implications for the non-availability or limited availability of essential health services could be very severe. UNICEF has forewarned that India would have the highest number of babies at 20 million in the 9 months post the span dating from when COVID-19 was declared a pandemic. Violence, as was mentioned earlier, has been a global concern, and COVID-19 times, there have been several reports in India, manifold reports in intimate partner violence. Yet reliable data does not exist, and that's something we have to be very concerned about, that the data is sporadic and very underestimates. All we can say is that whatever numbers we have are grossly underreported. With limited permissible movement, a number of women are captured with the perpetrators of violence in a house, within the house, and they cannot do formal complaints, even though we know there is underreporting. Can we go to the second slide? So what are the yeah. So let me move to, we all know what the problems are. Let me try and focus a few minutes on the solutions as asked by the chair. So we need to ensure women's health does not continue to be on the fringes, and whatever research we do as a gendered response. You know, during Zika, post-Zika and SARS virus, we had only 1% of the global research was gendered and looked at disaggregated data. So it is important to also, for us not to view COVID-19 as a standalone disaster impacting the world, and prepare ourselves for adequate knowledge on using gender disaggregated data and evidence. I believe that there is, if you look at the research or the surveys that are being done, even in the last 6 months, we have rich data, disaggregated data, which we need to analyze and ensure that what happened post-Ebola outbreak actually does not happen, Zika and Ebola. 2, there is a need to ensure uninterrupted provision of reproductive health services. These should not just be considered essential services, but these should be considered investments. Family planning is one of the best investments in preventing maternal child health, and especially in this time, there is so much, there's such a huge impact on and effect on mental health, and pregnant women and pregnancies, and the lack of access to abortion services. Abortion services have almost disappeared at this point of time. Both we are led down by not just the public sector, but also the private sector. So studies from across the globe have revealed how the lack of investment in family planning is impacting public health measures and development, which is really a best buy for, if you look at women and girls. It is also very important to strengthen counseling services through helplines, as well as building capacities of frontline health workers, who are often the only point of contact for the community. And large number of women across India in the villages not only deal with frontline health workers on an ongoing basis, but during the COVID, that really is the only point of contact. And 3, violence against women, coming back to it, and girls. there is no substitute to it being part of the public health system. In India and many other countries, violence, the doctor, the frontline health workers, everybody looks away because they're not mandated to factor in violence when they see the wounds even. So public health response has to be something post-COVID or even during COVID. We really need to have a public health response. Primarily, I say this because they are the only people who the government, the women come into contact with. But there are other reasons, other good reasons. I believe public health system has the capability. Finally, my last point is that the pandemic continues to, we need to continue to spread health education. Health education, we realized during the COVID pandemic, there was very little health education that we do, which is needed as a preventive and promotive measure in any case. And social and behavior change strategies will play a crucial role in fighting the stigma and discrimination that Soumya referred to, not only basis of religion, but there is a fear, the kind of fear that we saw during HIV/AIDS. And you rightly said, Soumya, it was the community that worked on dealing with the stigma and discrimination. And at this point of time, given the regressive social norms which differentiate between women and girls, we also need to empower our frontline health workers with tools for health education, communication, and behavior change, not only as a response to COVID-19, but also all the other aspects which are so correlated to women's well-being. And unless we put women at the center of, and therefore I'm really delighted to hear that the Meena Swaminathan Fellowship, where we need more coverage in the media, we hope that this will lead to women writing more on gender issues, and that there will be other fellowships, and there'll be many more Meena Swaminathan Fellowships joining the MS Swaminathan Foundation. Thank you.
Thank you. Thank you so much, Poonam, for those excellent comments. And I think our next speaker can maybe pick up where you left off in terms of the community response, what it's been so far and what we would like to see. So our next panelist is Dr. Kezevino Aram, who serves as a president of the Shanti Ashram in Coimbatore. It's a development organization that she's been leading since 2014. Vino is a child health practitioner by training with a passion for public health and a double specialization from Harvard University and decades of experience in actually implementing policies and programs, including child protection and through community participation. She's also a trustee of the MSSRF. So what I'd like to ask you, Vino, if you could address this issue of community mobilization and participation, because this pandemic has actually required far more awareness and mobilization at the community level. And what has been your experience of both community engagement and response working in Coimbatore? I don't think Vinu has slides, does she?
No, I don't have
So maybe
slides.
you can take the first question and then we can move on. Yeah.
Thank you, Soumya. Thank you for the questions. And it's good to follow up from the big picture to what could be also looking at a community scenario. It's interesting for all of us, this lockdown has meant different things, but it has also meant for some of us to be in our own places of work continuously for 3 to 4 months now, and to look at what is going around us. I think I want to continue with what Nitya mentioned as well. When the lockdown started, there was an immediate disruption of livelihoods for very many women, particularly women in the informal sector and women who are already living in poverty. And this disruption meant straight away a drop in income. But eventually what it has led to with the third and the fourth lockdown extensions is that they've become almost vulnerable, having to work under very difficult circumstances. They've had to negotiate not only incomes for their families, but they've also had to, I think, borrow. The debt burden that is also coming alongside the lockdowns for low-income families is something that I'd like to mention. But may I focus in my 5 or 6 minutes on only two issues, Soumya, that you raised, and I want to maybe elaborate that from a community point of view. One is the care burden. Nitya already highlighted to us about how the woman in the family suddenly has to take upon herself multiple roles that she was sharing before. Care of children that she was sharing with the schools, with teachers. Care of children that she was sharing with other support services that were available in the community, like the government's ICDS program and others. So this increased burden, along with compounded with having to work for the family and ensure income, has meant that she is really exhausted. And I have been speaking about fatigue, and not just care burden, but also a leadership fatigue that is setting in the community amongst women who have been relentless, having to compensate income, having to compensate for all the services that was also being provided from outside. Let me take one anecdote and then expound on this as to what I mean when at the community level this care burden has gone up. I have been working in the area of children and HIV now for about 20 years, and we have a cohort of children with HIV who work with us. We've had monthly interactions with them because, as we know, not just low-income families and already vulnerable sections of the society have had to bear a greater burden of the impact of the COVID pandemic, but they've also been at the receiving end, and some of the old memories of stigma and discrimination are coming up. So not only do you have the first level of burden, which is losing jobs or having to go back to work at very difficult circumstance, at income levels that are decided at an ad hoc basis, all of this together. Some of them have also been refused work. And for the HIV families, this is a second cycle of stigma, discrimination, disease, and deprivation. So I think one of the things that I feel will be very important as the unlocking or the lockdown, whatever way you want to call it, goes forward during the pandemic is to analyze it not only at the national level, at the state level, but also use the instruments of governance that we have at the panchayat level to see what are the particular support services that women will need. So gendered programming task forces that will look at this is something that I want to highlight. The care burden also has meant not only fatigue, it has meant disruption of access to health services. It has meant also losing out on that early window of early detection and care. So we have seen in healthcare institutions, one after the other, that in the primary care settings, utilization of health services has come down. Immunization, for example, even though it is available, it has been provided for in Tamil Nadu, routine immunization has come down significantly, just like antenatal services. Now, while we speak of care burden, I think we also have to see how these social safety nets at the local level can be developed. Of course, what Dr. SoumyaSwaminathan said about data becomes relevant for the entire world, for India as well, that these lockdowns will become more localized. Data coming out from the field will allow us to have more particular and more informed responses. But I think we'll also have to see where these services have found their way to women in particular. So, we were speaking of reproductive and sexual health services, but I think one of the key services that have to go on would be to ensure food security. The Tamil Nadu government initially had a universal approach providing everyone. Now they have, as Nitya mentioned, have said that they would give cereals. But in this portfolio, I think we will also have to be able to hear women and what they feel could be valuable support. One viewpoint that I hear from the community more and more now is about cooking fuels, the availability and access at home to also LPG cylinders and others. So not only the long hours, the disruption or the discontinuation of the packages that the government has put, but also all the other elements that ensure that the care burden is not compounded but reduced. The second one I think I really want to say is I think we've not taken the time during the COVID pandemic to see how the frontline workers, Soumya listed all of them for us, and the frontline workers have been disproportionately women, how their particular needs have not been met. I mean, just in Tamil Nadu, the disruption of public transport, for example, has meant that these women have had to organize multiple channels of ensuring that they arrive on time. They go to these new community clinics that have been set up, for example, in Tamil Nadu, the fever clinics. They've had to organize meetings. They've had to access technology. So I think the frontline workers, especially because they are made up by women in greater numbers, need 3 or 4 areas of particular help. So there is problems on one side, and then I'm also listing the areas where I think they will need more help. One is their own safety. I think their own safety, Dr. Swaminathan spoke about the PPE kits availability, ensuring that it's available on time and they can use it, ensuring that what takes them to work is also available for them, transport, rest, sick leave, access to testing, frontline testing, testing for frontline workers. The third, I think, is, we spoke of health education. It might be a window of opportunity for us to see what are the challenges. So many of our ICDS workers and village health nurses have said that their digital packages and their phones do not support the kind of material that is coming in for dissemination at the community level. And therefore, I feel that we don't have to look at the safety, the needs of our frontline workers who are disproportionately women only from a traditional lens. But the COVID-19 pandemic must allow us also to see how this could be an opportunity for us not only to make their voice visible, their work more counted, but also how they can be supported in new ways in which they can be more effective on the front line. But the 3 key concerns that I see in the field has been loss of income. Loss of income. I think we had a small study done last month when we completed 100 days of the lockdown. And in the 100 villages that we serve, the range of the income drop has been as deep as 60%. And this is something that we have to see. It could mean even an immediate look at the informal sector and what protective measures in the short term can be met so that women are not exploited. Secondly, how women are also ensured safety and security. Violence, we've all spoken about, how the judicial system, the police system, how reporting from the community can go up. But the other thing that is also, I think, equally important is maybe this will be a moment, just like the HIV pandemic, is how mental health services and mental health literacy can be expanded much more. And therefore, I feel that while this is showing out in terms of problems, existing problems exacerbating, it's also highlighting that there are some areas that we have not thought before, like protection of women in the informal sector, helping women frontline workers to overcome the digital divide, ensuring that there is a genuine bi-directional flow of experience and expertise, both from the policy level, but also from the field level. And I think from a community point of view, I feel never before has it been so important for public health interventions to look at also decentralized governance as an important vehicle and medium of building composite responses to the COVID-19 pandemic.
Thank you so much, Vinu. I think that's a really important point that you ended on. Decentralized governance has been one of the factors which has played an important role in those areas where the response has actually been more effective. So I think that's very good. And also the point you made about the digital technologies and tools which we are relying on more and more, we need to make sure that our frontline workers have the infrastructure or the hardware provided so that they can best use this huge amount of information that's now being digitally produced. And we have to make sure that it goes all the way down to the last mile, both for the providers as well as the recipients of healthcare services. So, and that is something that can last beyond the pandemic. It can be an investment made now, which can actually have far-reaching changes, impacts on healthcare delivery, particularly in remote areas. Moving on to education and what's been the impact of the pandemic on children's education, I'd like to invite Dr. Anjana Mangalagiri, who is an educationist who's been with UNICEF for many, many years and has worked as the Chief of Education in UNICEF, Bangladesh, Mozambique, and in China, and is currently Senior Fellow at the Institute of Social Sciences in New Delhi. She's also the country representative of the online network of the South Asia Forum of Early Childhood Development Professionals. So, Anjana, I'd like to ask you about what has been really the impact, differentiated impact of COVID on children's early development and schooling, because that's an area that you've been very closely involved with for many, many years. We all know there's been an impact, so if you could explain that, and then what steps can be taken to mitigate that impact. What about school openings, for example? There's a lot of discussion and debate all over the world on how and where and when schools can be opened. Over to you, Anjana. Anjana, can you unmute yourself?
I did unmute myself. Can you hear me?
We can hear you now. Yes, carry on.
Thanks very much, first of all, for having me on this panel, and I'm really honored and delighted to join this panel and the annual consultation. I must apologize that I have missed most of the presentations except the last one. Because I was having technical difficulties on from your side for a change, not from my side, in connecting. Anyway, so if I'm going to make any repetitions, what has already been said, please forgive me, but hopefully not, since my topic is totally different. So let me start by giving some shocking figures to say that in India, 28 million children have been impacted by the closure of Anganwadi centers. And this is, I'm talking about early learning and early development. And 247 million children have been affected by the closure of schools. Now, this is in addition to this more than 6 million girls and boys who were already out of school prior to the COVID crisis. So the big picture impact of COVID, as I see it, is really at 3 levels. One, it has exposed and deepened the class differentiated cracks affecting children's basic rights that pre-existed amongst urban and rural children, rural poor children, such as multiple deprivations in health, nutrition, water and sanitation, lack of protection from abuse, low learning levels. These have only got magnified and intensified by the COVID crisis. And prevailing gender discriminatory practices within families have only got exacerbated. Pre-pandemic, as we all know, and Soumya, you all know more than anybody else, that 38.4% of children pre-pandemic below 5 years were stunted and 36% underweight. And India had already slipped to 112th position out of 117 countries in global hunger. And 156 million children in India live in multi-dimensional poverty. The COVID-19 situation could push another additional 120 million children into poverty within 6 months, compounding deprivations and gender inequalities. COVID has also, and secondly, that was my first, overall impact. Second, COVID has revealed that that children are the least of government's priorities. The Convention on the Rights of the Child talks of the indivisibility of children's rights. Far from that, the COVID crisis has led to the invisibility of their rights and needs. Thirdly, the decades of progress made in reducing infant mortality, malnutrition, stunting, wasting in children, etc., access to early learning centers, improved indicators on girls' education, all stand threatened to be reversed. The pandemic compounded with economic recession is potentially retrogressing children's growth and development. In other words, there is already a humanitarian crisis in the making, and children will be the hardest hit. And specifically on early childhood development, this has always been a blind spot. Due to the extreme hardship and economic distress suffered by low-income households in rural and urban areas across the country because of COVID, and especially amongst migrating families, millions are facing severe hunger and disruption of all essential services, including the early learning for their young children. This will have both an not only a deleterious impact on the children, but this will have both immediate and long-term negative impact on the lives of children, girls, and a disproportionate burden on women who, on average, spend more than three times longer in care and housework than men. In the case of schooling and education, there are 4 roadblocks that have been impacted because of COVID and severely threatening the progress made on girls' education in particular. 1, the rural-urban and gender-biased digital divide. Only a quarter of households, about 24% in India, have access to the internet. Second, absence of meals due to the school closure. Third, the decreased incentive for girls' return to school due to extreme hardships faced by families. Fourth, the potential delays and even cuts in funding of existing schemes promoting girls' education due to the economic downturn. So poverty and survival needs intensify gender discrimination and patriarchy, undoing any progression made in girls' education. Now, evidence from studies done on the impact of Ebola, for instance, the Ebola crisis on girls' education, showed significant dropout amongst girls due to an increase in domestic responsibilities and income generation, etc. In most cases, boys, of course, were prioritized to attend school. In India, there is already a strong circumstantial evidence emerging of how children are being now sent out to work. Given the limited social security net, in India, the increasing domestic financial burden is already forcing parents to evaluate the opportunity cost of sending girls to school. It is estimated that nearly 10 million secondary girls in India could drop out of school, putting them at risk of early marriage, early pregnancy, poverty, gender-based violence, etc. Now, that I feel is really summarizes the impact on early development and learning. If you want, I could go on to talk about the next steps that could be taken to mitigate the impact. Should I?
Yes. Could you briefly mention what you think could be the steps taken to mitigate this?
Yeah.
Because you've obviously laid out some very grave, a very grave situation unfolding.
Yes, yes. That is a reality, unfortunately. Now, given the time constraint, I will highlight only the most critical interventions that need to be made. First and foremost, and some of my earlier, colleagues also mentioned about, the Anganwadi workers. The Anganwadi workers need to be released from COVID-related duties so that they can focus on their primary job. And the government needs to seriously consider providing them formal recognition. Secondly, there's a need for quick cluster-specific mapping exercises that, in all vulnerable districts, especially those with reverse migration populations and in urban slums, to update existing data on children below 6 along with their health and nutritional status, and to bring them within the fold of the Anganwadi system, those who are not, of children from the migrant, of people from the migrant families who've gone back home. Similarly, block education offices need to identify new students, the new students that have now, come back, and track girls' enrollment and attendance in order to develop a gender-responsive education planning and budgeting. Then again, the indivisibility of children's rights must be recognized and an integrated package of interventions developed that address children's survival, nutrition, early learning, protection needs, critical parenting, along with the critical parenting information and messages communicated by the Anganwadi workers during home visits, as also through low-tech blended media approaches, as long as the Anganwadi centers remain closed. Some countries, in fact, have initiated daily broadcasts on parenting information, including on play activities for their children, through national television and radio. Another recommendation that I would like to strongly make is that UNICEF has proposed, for an emergency universal child benefit. And that is worth considering, even if for the most vulnerable families, even if not universal, but just for the most vulnerable families, it's worth considering. Children's nutrition. There's too much hunger happening, in the country amongst the low income households. Then, with reference to online learning, the one-size-fits-all, model will not work. It does not work, and it immediately eliminates girls and children living in rural and remote areas. Again, the radio lessons have to be that have proven to be particularly popular in terms of outreach to marginalized populations. Well worth considering. Now, Soumya, you asked me when are schools really, going to be, is good for them to open. Well, I feel that as long as, for me, I'm not really talking about, schools in urban areas for the middle classes and upper. I'm talking of schools, in the rural areas and the Anganwadi centers in the rural areas, and where children, have been displaced, especially where children have been displaced. Now, unless we do not have, even if the schools were to open, it's not a question of when schools should open. It's how much parents feel confident to send their children to school, not so much because of the infection, but because of their daily existential circumstances. And that's why I'm talking about the child benefit that families need to be getting. Post-COVID, the state education and the WCD departments, the Women and Child Development departments, will need to undertake careful planning for ensuring safe environment in schools and the Anganwadi centers in terms of availability of water, hand washing, hygiene, sanitation facilities, and guidance for teachers to be especially sensitive to ensure that the classroom experience of students from poorer and marginalized households is not marred by the disease stigma that has happened so much in our country, especially against specific communities, or the bullying by students. And funding to existing schemes promoting girls' education must be reinforced and not reduced in the name of the economic recession that is happening. Finally, I'd like to say that given the hugely adverse effects on early childhood development and schooling and the potential long-term impact on children due to the pandemic, there are serious policy implications to be taken into consideration based on the lessons learned. The recent release of the National Education Policy could have been postponed in order to incorporate these. Is it reflective of the insensitivity to the differentiated impact of COVID on children's development and learning? I don't know. Because we cannot allow children from low-income households to become the collateral damage in the fight against the virus. And we must not let decades of progress at the same time, the decades of progress on child development and education indicators be lost. Thank you.
Thank you so much, Anjana, and that I think your points were not really duplicating any of the previous speakers and very, very important issues that you've raised. So I'd like to go to our last panelist now, Dr. Avni Amin, who's a technical officer for violence against women in the WHO Department of Sexual and Reproductive Health and Research. She also heads the department's work on gender equality in relation to sexual and reproductive health issues. So Avni, could you, from a global perspective, talk about what the trends have been across countries in terms of the gendered impacts of the pandemic, and also are there any good examples in terms of a potential rise in gender-based violence and broader inequalities? Any good case studies that we could learn from? Over to you, Avni.
Thank you, Soumya. For the first question, I'm going to just share some data, global data, if that's okay. Is it okay if I share my screen?
Yes, that should be fine.
Okay. So I'll just pick up from one of the points that Soumya made about limited sex disaggregated data, and maybe speak to what happens and what data and what evidence becomes very apparent when data disaggregated by sex is available for COVID.
Could you go to slideshow, Avni?
Yeah.
Might be clearer. Yeah.
Yeah. Just 1 second. Yeah. So I'm going to first point to one source of sex disaggregated data that we have outside of WHO, and then some of the data that are emerging from what countries are reporting to WHO. First is this Global Health 50/50 COVID-19 sex disaggregated data tracker. And what becomes quite obvious when you look at what countries are reporting to this particular tracker, I mean, they're looking at different sources of data, is that we don't actually have a clear pattern of who is becoming infected by sex. So in some countries, there are more men than women, and in others, it's more women than men. And there are several reasons for that, and some of it has to do with what kind of data, what kind of testing is being done, and what is being reported. When you look at data that is being reported to WHO by sex, and this is from the WHO Southeast Asia Regional Office as of August 6th, and with credit to our regional office for sharing this data, and with the caveat that this is not complete data. And in fact, one of the countries where sex disaggregated data are not being reported to IHR and are hence not reflected in this is India, which, as you all know, has the highest number of cases. So we see for Southeast Asia regional office countries, the men still dominate in the number of cases reported by sex, as well as in the death rates or the case fatality rates. However, as I said, this needs to be interpreted with caution because we don't have actually data from India on this. When you look at the global pattern of who is more likely to die, there is a general sense that if you look at the male to female ratios of deaths confirmed, that men are more likely to die. However, again, I just wanted to, exercise a little bit of caution and caveat, because you will see that in some countries that is not the case, and these are the countries at the bottom of this graph where it seems that more women are likely to die than men. This is data that is reported to WHO, to the WHO Eastern Mediterranean Regional Office, and again caveated to the fact that this is based on only 37% of case report forms that were sharing sex disaggregated data, and one of the countries in that region which has the highest burden, which is Iran, is not represented in this graph. And you see that for whatever reasons here, actually women seem to be more represented in the number of cases who have died. Women are slightly higher in the severity of cases in terms of people who are on ventilators. However, men are more represented in the symptoms, the severe symptoms like shortness of breath. But once this full picture emerges, we may see a change in this pattern as well. Then what about pregnant women? And until recently, the assumption was that pregnant women are not at higher risk of severity than the general population for COVID. But and that is the case when it comes to acquiring COVID-19. However, there are two studies that have just emerged, one from the US CDC and one from Sweden, of pregnant women, where what we are seeing is that pregnant women with COVID are 50% more likely to end up in ICU and 70% more likely to need ventilators, though they're not more likely to die. And similarly for Sweden, we are seeing that pregnant or immediately postpartum women with COVID-19 are nearly 6 times as likely to land up in ICU as non-pregnant women. And I think one of the things that we might look at for explanations is immune system changes and strain on the cardiovascular system during pregnancy, which might explain this. So if you have to explain why men are more likely to die from COVID once infected than women, there are some explanations, and this was published actually in the Nature Immunological Review very recently, and the work was done by Sabra Klein at Hopkins and her colleagues, who have looked at biological sex differences in immune responses for infectious disease and respiratory illnesses, for SARS and many other MERS and other infectious diseases. And there are two likely explanations for this. One is basically that biologically, the X chromosome has essentially more immunological response genes, and that estrogen has a actually protective effect on acquiring and more severe impacts of the infection. And in general, what we have noticed in other infectious diseases, including studies that were done in mice, is that men tend to have a higher antiviral immunological response compared to women, precisely because of the protective effects of estrogen. Now, obviously, this has implications for women who are postmenopausal. And in fact, in Wuhan, they did look at the estrogen impacts of women with more severe COVID, and they found actually that they had less estrogen compared to the ones who had less severe COVID symptoms. One of the main things, apart from biology, we have also looked at the gendered health behaviors and comorbidities. And this is data reported from the WHO EMRO region. And what we see is obviously cardiovascular, including hypertension and diabetes, being the two comorbid conditions that lend itself to to deaths and severity. And here, for many reasons, some related to data artifact, you see that women are actually more represented in cases of deaths due to cardiovascular disease and diabetes. And maybe this may change once a bigger picture emerges, but it's just something to keep in mind, especially if you're looking at the links between diet, NCDs, comorbidities, and COVID in some of the data, and some of the gender-related underlying factors that dominate in this case on health behaviors. We know, as Soumya mentioned, that men and women do have different risks of exposure. And we know from a lot of behavioral studies on smoking and alcohol that men generally tend to have a higher rate of smoking and alcohol use. And there's a very interesting study that was published in PLOS One in 2016 that looked at the association between gender and protective behaviors in response to respiratory epidemics and pandemics. And what they looked at was the prevalence of non-pharmaceutical behaviors, such as hand washing, using tissues when coughing or sneezing, face mask wearing, surface cleaning, etc., and avoiding crowds, public transport, all the things that are right now being told for COVID. And they found that in general, men were 50% less likely, or women were 50% more likely, as seen in this graph with the red sort of area, to adopt protective behaviors in response to respiratory epidemics. And in fact, even now there are studies that show that men are less likely to engage in hand washing, but the big caveat is that women have less access to means for hand washing because of gender inequalities, as well as wearing masks. So those are just things, interesting differences, gender differences to consider when thinking about the gendered response to COVID. Then Soumya specifically asked about the physical lockdown and distancing and travel restrictions, and some of the other speakers have already spoken to the impacts, including economic insecurity, disproportionate burden of care, mobility, shutting of schools, and then looking at specific populations of women. But I wanted to share some data that is coming from our WHO's Western Pacific Regional Office, who is also doing a gender analysis of data in their region. And in 3 countries, you see essentially that, women, the burden of care, increased time in unpaid and domestic care has dramatically gone up for women compared to men. And here women are represented in the blue bars and men are represented in the yellow bars. And this is for 3 countries, Philippines, Cambodia, and Samoa. So you begin to see the actual sort of evidence of what people have been talking about with respect to what is happening in India as well. Domestic violence has been spoken of quite extensively by the previous speakers, but maybe I just wanted to flag 2 things about domestic violence here and the impacts of it. And that is that, intimate partner violence was quite widespread before this epidemic began. What we are seeing is not that the prevalence has gone up, and that's why I want to exercise caution about what the data are saying. But among women who are already in domestic violence relationships, what we are seeing is the lockdown measures, the economic insecurity, and the stress that has been brought on by the pandemic is increasing the frequency and severity, and the reports are quite variable, because in some countries the reports have gone up, and other countries, because of lockdown measures, women have actually not had means to report domestic violence to relevant authorities, and therefore the reporting has gone down. So I just wanted to maybe, put caution to interpreting this sort of blanket thing that prevalence has gone up, which we don't know that. Prevalence was quite high to begin with. But what we might be seeing is frequency and severity of the violence might be going up because of the lockdown measures. And here I will probably switch more to what WHO, as well as some of the good practices that Soumya mentioned, are being put in place in response to domestic violence. We are in the process of compiling what countries are doing in a systematic way to respond to domestic violence during the lockdown measures. But some of the examples that are coming up, for example, France, the government has actually invested in paying for hotels so that women who need to leave urgently from their homes because of safety concerns can actually leave their homes and be safe. In Italy, for example, pharmacies have become a place where there is information available about a more discreet way for women to report domestic violence. And one of the things that is really important to remember here is that because of lockdown measures, the perpetrators are at home. So there's really an issue of even women reporting in a safe way. And so there's a lot of messaging out there that countries are experimenting with to figure out code words like help or some other ways in which they can signal that they need to, on an urgent basis, get out of the homes and get help. In Switzerland, where I live, and I have seen this myself, in every health facility, including when I take my children for healthcare, they have signs up for where you can get help for domestic violence if you're experiencing domestic violence in relation to COVID. And Canada has actually just announced a $1 billion, the government has announced $1 billion for Indigenous as well as Canadian groups providing frontline psychological support, including through remote means. And then just in terms of a very good example that has just emerged for a very comprehensive, what we call a feminist post-COVID recovery plan, and that is also available online for people to see, is Hawaii has just spelled out what a post-COVID feminist plan would look like, which has specific recommendations for austerity measures to not cut back on sexual and reproductive health services, and for any revenues that are raised, that there is investments in public housing, support for parents and caregivers, for training of health workers, as well as for targeting the needs of high-risk groups in the state. And of course, these are high-income country examples, but I think that there are emerging examples also coming from low and middle-income countries that are experimenting with different ways to respond to the gender dimensions of COVID. Maybe one last thing I will end with is that, as we think of also the research and development agenda, the importance of addressing gender in the COVID response, and an analysis that our department is doing is suggesting that of the 1,100 therapeutic trials registered for COVID, 80% of them are excluding pregnant women, even though the safety of the drugs has been shown to be the case for pregnant women, because these are not new drugs. These were already trialed for other purposes. We know from a long history of clinical trials before COVID that there is a very significant bias where clinical trials in general don't include women, and often the dosages of vaccines and drugs and things are based on male bodies. And most clinical trials don't actually make a proactive effort to overcome women's participation in clinical trials, and don't share data on outcomes that are disaggregated by sex. And so it's maybe just something to close with, that in addition to thinking about the good practices in domestic violence, that perhaps even thinking about how we can take and shape the research and development agenda for COVID, we need to perhaps also think about how women can be represented in the clinical trials, so that when these vaccines and drugs become available, the benefits actually can be accrued to women as well, not just in terms of access, but also in understanding how these drugs and vaccines work differently in men and women's bodies, precisely for some of the reasons I articulated earlier, which is that we're looking at very different immunological responses for men and women in general, apart from the gender impacts of this epidemic. And just as a closing, the plea that we really have to encourage countries to prioritize collection and analysis of sex disaggregated and other gender data, because we are flying blind when it comes to addressing this epidemic in absence of such data. And when this data is available, it can tell you very important things about the epidemic. Thank you.
Thank you. Thank you very much, Avni, and especially for the call, both for gender disaggregated routine data that's being collected, but also for the inclusion of women and girls in clinical trials. I'm going to now request, we've had very active audience participation, and I think you'll all agree that we've had 5 excellent presentations, and each of the speakers has addressed huge variety of topics in the limited time that was available. And we have only about 10 minutes. So what I'm going to request Jayashree to do is to quickly tell us some of the questions that we've been receiving from the audience. And I'm going to ask each of the panelists to perhaps just take 1 minute to respond to what you think is the key, one of the key topics. And we apologize that we will not be able to answer all the questions that we've received today.
Thank you, audience, for very active questions, and to very quickly run through. Some of them are specifically addressed, like Dr. Rajiv Ashni from ICRISAT, who says a very nice talk and asks about the violence data recording from WHO perspective. Is it in both developed and developing countries, and is there any correlation with education, financial, family status? And thanks you for spreading awareness through Twitter about best practices and health tips, which are very useful. A related question from Padmaja from ICRISAT, who also says it's more like an observation that there is widespread violence even in urban slums in India. And Ram, Janik Ram, who's offering, disaggregated, validated data from, and would like to explain this more in detail. So that's, thank you for that, Ram. And one more last question for you at this point is that, do we need caste group specific data from, based on different caste groups from Dr. Gopinath? Actually, one of the last chats we had is also about sexuality in terms of understanding homosexual communities and seeking health at this point of time. So that might be either for you or for Poonam, but these are the first few questions for you.
So I think very quickly, I think all of these reiterate the importance of data that's disaggregated by many of the factors that we talked about. And I think that at least at the WHO, we're dependent on what countries provide us. And as Avni pointed out, we have big gaps in the data that we receive. But as far as the countries themselves are concerned, I think there are huge opportunities to use existing institutions, existing scientific expertise available, especially in data science, to really understand more, not just about the COVID-19 and where it's spreading and how and why. That itself is very important. But then it also informs the public health response, and it informs where one should be targeting the interventions, like specifically on women or children or other marginalized groups, including the sexual and other ethnic or caste minorities. So I think these are all important points which we really need to consider going forward.
And next to Professor Nitya Rao from Dr. Rajgopal, who appreciates the points mentioned. So does Padmaja, specific to food and nutrition security. And a specific question to Dr. Nitya Rao is, has anyone studying the long-term impacts of not having regular health and nutrition service? So this is a question.
Yeah, thank you. I think...
Sorry, just to add one more question from Dr. Lalita Bhattacharjee from the FAO, who says that given the need to revitalize value chains, is there any measures taken across South Asia to activate women more effectively in agro-processing of micronutrient-dense foods and value additions in SMEs? So that's one more.
Yeah, thank you. I think long-term impacts, no, we don't know yet. I think it's still guesswork, that assuming that Anganwadis are not providing food. And as I said, in most cases, this is not additional food. It's really replacement food, because poor households, they just replace that meal. That means the consumption of children has actually declined, and of all pregnant and lactating women as well, in the absence of that food. So we don't know yet. I think we will have to see 9 months or a year down the line, what are the longer term effects. In terms of supply chains, I think that's a very good point. I think, there's been a lot of talk about women in the public sphere. So Kerala women in self-help groups, they're producing food even when schools are closed to distribute in the community. Or in Uttarakhand, there are women who are producing nutritious meal, which is then bought by the ICDS and distributed. So there has been a lot of focus on women's self-help groups and so on. And I think there is some new policies also in terms of farmer producer organizations, which the National Agricultural Bank and for Agriculture and Rural Development has announced. But unfortunately, the scale of enterprise is really large. So we don't know that the smaller scale FPOs, particularly those run by women, how much they will actually be able to benefit from this support. Second thing, a lot of it is loan-based or credit-based rather than grant-based. So I think women's enterprises are often smaller scale, they're often voluntary, and in this particular context, it seems to be putting them at a disadvantage in terms of being able to compete with the other more established medium and small scale enterprises. Thank you.
To Dr. Vinu Aram, there are two questions specifically addressed to you. One from Beena Agarwal, who says, do you think universal basic income could provide the support women need normally during crisis and pandemics? And Anita Cheria, who says it's useful to know more about innovations and solutions that have worked locally or based on community resources involving particular stakeholders. If you could unmute yourself, please. Could you unmute Dr. Vinu Aram's mic?
Yeah.
Yeah, we can hear you now, yes.
Yeah, I'll take my minute to say, I think we all have acknowledged that there is an uneven burden. And not only is this uneven burden on women, but within the community of women, there's again a compounded burden on people living with HIV, on single mother-headed families, on women living in extreme poverty. Now, in terms of what can universal income, I think these discussions are are to be done now, because we have seen as evidence during the lockdown and this pandemic that women's livelihoods are very, very, very fragile, and income can be disrupted anytime. So I think if we want to build back better, we will have to speak of these fundamental issues. And I think just like the national education policy, there might be things that we can take back to build back better after the pandemic. In terms of the second question, one of the studies that we did was utilization of the public distribution system, not only of the food security packages, but also, for example, in Tamil Nadu, the direct benefit transfer or the direct cash transfer in this case was done by the PDS. And the Women's Self-Help Group in Tamil Nadu run a number of PDS shops. So I think the uptake architecture that some of the women and women-based enterprises and organizations can provide in complementing decentralized governance, I think is something that has come up. I think we should explore this more also for public health, as to more integration at the community level of these responses, and how both data but also a commitment to strengthening of decentralized governance can help us meet these extreme needs, not only during the pandemic, but post-pandemic as well. So I think if we want to build back better post-pandemic, I think the livelihood issue, the income issue, but also how we utilize the architecture, the uptake architecture that women have created as voluntary groups, as community groups, we'll have to see how that connectivity can also be done. Thank you.
Thank you. So there's a generic question from Dr. Arvind Padi, who says, excellent thoughts, but the gaps, gender gaps are high in rural areas where cash, food or assistance by the government is given to the male head of the household. For nutrition outcome, women's asset ownership and empowerment should be a key priority in pandemic response and recovery. I will leave that question open and go on to a couple of questions on the Anganwadi workers and the school education that were addressed to Anjana. In fact, there have been a few interesting, few people who've expressed interest at that. One is that in terms of the Anganwadi workers, agreeing that yes, the NEP could have been on hold for a while, but improving Anganwadi facilities is important. But more resources spent on awareness on wash and relatively less resources for water and toilets could be an opportunity to improve Anganwadi services. This is more a comment than a question, I think. So safety measures for workers and children would instill confidence. And when the pandemic will be over, we cannot say, but both schools and Anganwadi centers should be equipped to address children's needs. When these facilities will be open, at that time there should not be more hutch-patch. Okay, I think basically this is not much, confusion at this point. So, yes, if Anjana would like to answer, and the other question also, the generic question also, if you would like to answer. Dr. Anjana, yeah.
Can you hear me?
Yes, we can hear you.
Which was the generic question? Could you just come back on the generic
question? Basically,
question?
the entitlements are in the name of the male. And do you think it's better that, so in the, go to the male, don't you think from the nutrition perspective, it's better that the women are the, have the rights to get these entitlements? So actually, in the Food Security Act, women do have, as per the law, women are the rights holders. But I think here the cash or food or assistance is given to the male head of the household in practicality. I think that's what Dr. Padi is saying. So shouldn't that be a key priority in pandemic response and recovery?
Well, in the Anganwadi centers, the food that is given out to pregnant women in the Anganwadi centers is directly given to the women. It's not in the name of the males. Because the pregnant women are registered with the Anganwadi centers and they get the food directly once they come to the centers. And of course, now it's being delivered, at home, but not across the country. It's only very few states who are actually caring to have the food ration delivered home to the pregnant women, and of course for the children. Most importantly, for the children. On the second one was a long comment, and I don't really quite disagree with any of the points that were made there. What's important to understand is that the Anganwadi worker, in these times, has been pulled a lot into all kinds of other work. Tracking and tracing COVID patients, and going and giving them, switching from messages on play activities and nutrition and etc. for children and women. They are now being used to give messages on protection from COVID house to house. That's unacceptable. Absolutely unacceptable. And as long as the Anganwadi centers remain closed, Anganwadi workers need to be fully engaged in following up with the children at in their homes, on and in having sessions with the mothers and the fathers, parents, on the kind of activities they can do with children, because children have been locked up, children are cooped up. But of course, in these in the lower income categories, we find that children are not so confined, and there are children who are really enjoying a lot more freedom, hopefully healthy freedom, than elsewhere. But it's important to have the Anganwadi workers work focused on women and children. That's the bottom line today. And the earlier the Anganwadi centers open, the better it would be for the Anganwadi worker to be equipped. Anganwadi worker, which I couldn't talk about much because of paucity of time, but it's extremely important to equip Anganwadi worker with an integrated package, along with the nutrition and water, sanitation, etc., with the play activities that not everywhere the Anganwadi workers are doing. This is extremely important. But of course, it all depends on how much the children, the extent to which the children will be able to come. That is one of the first things that the Anganwadi workers will need to do to bring children back to the centers. The parents will be very reluctant to release children.
So we have one question from Facebook. Dr. Balakrishnan asks if there is any way we can link this with the land rights to women that yesterday Professor spoke about in the inaugural session, and that was also taken up by the Vice President in his inaugural address. So the issues that we are discussing today, he's wondering if it can be linked. So I can see.
Yeah, I think, thank you for that. I think definitely it can be linked. I think I didn't have time to speak specifically on land, but I think my final slide in terms of longer term strategies was about ensuring equitable resource rights, both in terms of material rights, land rights, other technology, in terms of financial rights. So for instance, the Kisan credit cards, which have now been announced that the money to it is to be boosted, but women own only 2 to 4% of Kisan credit cards. So though they are farmers, 60% of agricultural work is performed by them, but they won't get access to finance under the new Atmanirbhar package. And the third, of course, is their own knowledge. So I think very important that not only land, but all resource entitlements, access to land, water, credit, plus knowledge, technology. And I think this is what Professor Swaminathan was talking about in terms of the draft Women Farmers Entitlement Bill, which was a much more holistic bill, which looked at land, but which also looked at all the other resources, that women should be recognized as farmers and they should have equal access to all resources as other farmers.
In fact, I think Dr. Lalita Kumar Mangalam is with us here today as part of this. Thank you very much for joining us. And she was part of the event that MSSRF did in order to push for policy on reinforcing land rights for women farmers. She's also asked for the presentations. We will share with those of you who have, said you would like to. We'll, with the, with the consent of the presenters, we'll share all the presentations. But this is available on YouTube for you to see. Just one question, I think, maybe one very last question for Ms. Muttreja, is that as we enter a disruptive health period, how do we ensure trauma of the marginalized is not on display? And ethics and mental health, is it a policy priority? And also, of course, linking to the earlier question about whether it is, whether people from the sexual minorities, whether they will be further pushed underground and will not be able to seek help for health. So if Ms. Muttreja, you can take on this question, please.
Yeah, so thank you. The trauma on the most disadvantaged, the most vulnerable is going to increase. Whatever we heard, whether it's education, health, livelihoods and so on, we don't need more evidence to know they'll be helped. They will be impacted most negatively with very serious consequences. So I think it is time. One of the post-responses or post-COVID responses has to be, instead of us saying 2 years from now we couldn't reach the last mile, let's do vulnerability mapping, which includes sexual minorities, and prioritize them. It is really, we are going to have limited resources, and it's really important that we do prioritize our budgets and so on. And this is something that I think there are 2 or 3 quick points that I want to make for WHO to consider, since we have a strong presence not only in Soumya, but we also have Avani. We really need to do a vulnerability mapping and focus a large percentage of the financial packages, access to vaccines and so on. I've heard Soumya talk many times about that, to the most disadvantaged, to developing countries and so on. Second, there are solutions. One policy we can have globally is that places where there isn't COVID infections, especially in a lot of the tribal areas, in a lot of the cities, decentralization has to take place, where the collector can make a decision. Even if you open the school for 20 days, it's very important. And kids can come on alternate days. I'm not laying out a policy, but we really need to have those kids back in school, where, especially in the most disadvantaged communities, where we know that the longer it takes to get schools open, the girls are going to go and they're going to be in sex trade, they're going to give up school, there'll be school dropouts, etc. On mental health, India, thanks to Dr. Vikram Patel and Mr. Keshav Desi Raju, who's attending this webinar, during his time, a mental health policy was made, but we haven't invested any resources and money in the mental health work. We need counseling right now, is a huge need with the kind of trauma and mental health distress we are seeing. I'm supporting a helpline where I just want to say to Avni, the highest number of calls are first women health workers who are experiencing huge anxiety since they don't have the right PPE gear, they don't have the training, they don't have they're overworked. And the second lot who are calling is women with huge domestic violence, and many of the cases are new. I know we need to develop the evidence, and I agree with you, Avani, that the women who already experience violence are getting worse treatment and abuse, but there are additional new large number of cases. So these 2 calls, and finally, I would like to say that one of the areas where a lot of NGOs have supported is sexual minorities, what we call eunuchs. They were starving in parts of Bengal and Bihar. And PFI, in fact, we decided that that's the area. I mean, those are the communities that we are going to support. And the more we supported the more we found out the kinds of discriminations, not just hunger. They're the first to get out of jobs. They're not getting, and they weren't under any scheme. And the NGOs are the ones who informed us, and it's primarily the NGOs that have worked with sexual minorities in India. And on the whole, you know, even when before the pandemic, the poor women, the Dalit women, the Muslim women get least access to family planning, institution deliveries, immunization, and which clearly exacerbates now. And finally, the fact that we have very few, we hardly have any Dalit, Muslim, Christian, ANMs, Ashas. The percentage is really low, it's negligible. If we really need to bring in more women from this group as frontline health workers and as everywhere.
Thank you very much, ma'am. And on that note of equity, it's been a very heartening panel to listen to diverse perspectives from the gendered lens. So I'd like to extend a very heartfelt thanks to Dr. Soumya for chairing this panel and for bringing everything together, all the pieces together. To Professor Nitya Rao, it's actually been her brainchild who the panel composes of and how to get in touch with them and reach out. So thank you very much for that. It was like putting a jigsaw together. It was very, very nicely done, and I'm glad I was able to watch and learn from that. To our speakers of today, Ms. Poonam Muttreja, Dr. Anjana Manglagiri, Dr. Venu Aram, and Dr. Avni Amin, thank you so much for joining us. And we also had a very rich, set of people listening in. Mr. N. Ram was there. Dr. Lalita Kumaramanglam is still online with us. Dr. Arvind Padi, I can see him. Dr. Vashni, Dr. Lalita Bhattacharjee. So we've really had a very rich set of listeners. And this is the kind of momentum that we hope to generate through this conference, that we can bring the pieces together and hopefully push for policy. So thank you very much, and look forward to you joining us tomorrow for the first session on value chains. It's on Monday. It's on Monday. We are shut down on Sunday. So Monday morning, our first session is on post-harvest markets and supply chains at 9:30 a.m. Indian Standard Time. Do join in, and we are looking forward again to taking some points ahead on that. Thank you very much.